Good morning, everyone. I'm Achala from Bangalore Medical College and Research Institute, Bangalore, Karnataka, India. Thank you for giving me this opportunity to present our project at AAPI. Today's topic, which I'll be presenting, is prevalence trends, outcomes, and predictors of mortality in pulmonary embolism. We have no disclosures and we have no fundings. These are our contributors. I'm very thankful to all of them to have fully contributed to the project and helping it make successful. So the background of the project is pulmonary embolism is the third most common vascular disease in the United States, frequently underdiagnosed and potentially fatal condition, where embolic material blocks one or more pulmonary arteries, impairing the blood flow. In this study, we aim to describe the prevalence, outcomes, and predictors of mortality of mechanical thrombectomy and surgical thrombectomy. Pulmonary embolism will be further addressed as PE, and mechanical and surgical thrombectomy will further be addressed as MT and ST, respectively. So these are our aims and objectives, which are primarily the outcomes as well, which we'll be focusing on the upcoming slides. So primarily, we want to study the utilization trends of pulmonary embolism, which are treated with MT and ST. Secondarily, we want to evaluate the mortality, discharge to facility, the periprocedural complications, and length of hospital stay. And tertiarily, to identify the predictors of in-hospital mortality. Coming to methods, this was a retrospective study using the Agency for Healthcare Research and Quality, HCUP NIS data from 2010 to 2018. We used the 9th and 10th revision of the International Classification of Diseases Clinical Modification Codes, which is ICD-9 and ICD-10, to identify the patients admitted with primary diagnosis of pulmonary embolism, the codes for which are here. Continuing with methods, we extracted demographics, hospital level, and patient level characteristics. We defined the severity of comorbid conditions using the DAYO modification of the Elixir Comorbidity Index. Like I had mentioned in my previous aims, primary outcomes were utilization trends of PE, which were treated with MT and ST. Secondary outcomes were mortality, discharge to facility, periprocedural complications, and length of hospital stay. Tertiary was to identify the predictors in hospital mortality. Coming to the results, from 2010 to 2018, there were around 1,627,718 hospitalizations for PE, out of which MT was 6,531, as in the patients who underwent MT was 6,531, and who underwent surgical thrombectomy was 3,465. Mechanical thrombectomy comprising of 0.39% and surgical thrombectomy comprising of 0.21%. Now, the utilization trend of mechanical thrombectomy and surgical thrombectomy increased. Mechanical thrombectomy increased from 336 to 1,655 from 2010 to 2018. In a similar way, surgical thrombectomy also increased from 260 to 430 in 2010 to 2018. Now, the unadjusted in-hospital mortality for mechanical thrombectomy was 9.1%, and mean length of hospital stay was 7 days, plus or minus 0.3. Similarly, for surgical thrombectomy, it was 13.9% in-hospital mortality, and mean LOS, which is length of hospital stay, was 13, plus or minus 0.4 days. Now, these were the utilization trends represent pictorially. Results were periprocedural complications for MT and ST were invasive mechanical ventilation with 13.8% and 32%, cardiopulmonary bypass with 3.3% and 68.3%, pulmonary embolectomy surgery 1.7%, and bleeding complications were 1.4% and 3.4%. Predictors associated with in-hospital mortality for MT was increasing age, female gender, large hospitals, teaching hospitals with the following odds ratio, confidence interval, and p-value. Predictor for in-hospital mortality for surgical thrombectomy was increased age with the respective odds ratio, confidence interval, and p-value. Conclusion, PE hospitalizations have slowly and steadily increased. There has been a drastic rise in using MT to treat hospitalized patients, which we clearly saw from our pictorial representation after the extraction of data. Further studies are needed to examine this increase. We have to do more studies to examine. So that is one of the gap in research. Take-home messages: we should aim to treat the symptoms and keep the patient alive by minimizing bleeding risk. Markers that supplement achieving our aims include strain on right ventricular function, elevated cardiac biomarkers, and pulmonary embolism scoring system. There was no acknowledgement. Thank you.